Dr. Joseph Saba, our guest and speaker for this afternoon session. Dr. Saba, good afternoon. Thank you so much for joining us.
Thank you. I'm glad to be here. Thank you very much for inviting me.
Lovely. A privilege and an honor to have you with us this evening, Doctor. Dr. Saba is the Chief Executive Officer of Axios International. And he's the co-founder as well. And what is Axios? Axios is a global healthcare consultancy. And what they do is actually build sustainable access solutions for low middle income countries. And what is good is they have a very proven track record of innovation, successful access strategies, new models for strengthening healthcare systems. And Dr. Saba himself is a physician. He's specialized in infectious disease, health management, medical statistics. He has degrees in medicine, medical statistics, communications and medical management from various institutions all across Europe and even the Middle East. And of course, Dr. Saba speaks Arabic, French, and English. He has an extensive background in working in low middle income countries with quite a few organizations, including the World Health Organization. And he ran things like the National Plan for HIV Vaccine Development, Global Program on AIDS in the WHO Department for Clinical Research and Drug Development, and in working on prevention of mother and child transmission of HIV/AIDS in many countries in Africa, as well as Doctor, you've done some work in Vietnam as well, yeah, in HIV/AIDS. Lovely. So what Dr. Saba brings to us this evening is this extensive wealth of experience, and he's going to come and provide insights on kind of how can we get our patients to reach the drugs that they need a little better. And perhaps that is the story that I'll leave Dr. Saba to speak about this evening. And I think we're kind of going to get you to work a little bit, so to kind of earn your theta ray. So I think Mr. Johnstons, who's another colleague of Dr. Saba at Axios, is going to, I think, run you through a poll. Is that it?
Yep, exactly. Yeah.
Okay.
So we are going to kick things off very soon, and Dr. Joseph will also run us through very soon the agenda as well as the objectives, of today's discussion. But in order to set the context, we have two poll questions that I will actually put on screen now, primarily focused on access in Malaysia as well as the different participants' take on access in Malaysia. So let me launch that poll now. And you should see on your screen now a poll. So there are two questions here. The first question is, what does increasing access to a product mean for you? Choose the top two answers. And the second question that we have on screen is, what are the two most significant barriers to access in Malaysia, in your opinion? And again, choose the top two answers. So I'll give everyone just a minute or two to complete this poll, and then we will start sharing our screen, and Dr. Joseph will also run us through the results as well, and we'll have a short discussion about them.
Okay, Johnston, sorry, I'm just going to ask you to share with our colleagues, how do we actually, I see that they're okay with answering. How do they actually answer, yeah?
Oh, I think people are able to answer, because I see some results coming in.
Yep.
Yeah, I see 5 of 36 have answered.
Okay, lovely.
Okay, about half of the participants have answered, so we'll give everyone just a minute more. And I will end the poll in just another 10 seconds. I believe we have most of the responses. All right, I'm going to end the poll now. I believe the results will show and share results. So I'm sharing the results now. Joseph, I'll pass the floor over to you then to share your screen as well as review the results.
Yes, sure. I think there is another poll just after it. The second question, do we do both together?
Johnston? Yeah, both were done together. Are you able to see the results on your screen?
Okay, they are, yes. So it's interesting. I mean, most of you, of course, price is coming as the first one, but not very far away. We have also the maximum medical benefit for the patient, which is the primary, I would say, objective of a physician toward a patient, and that's very interesting point related to that. And then the other aspect is patient understanding of treatment that is coming, on the top, and patient affordability, which links back to the price. We're going to talk about also the understanding of the disease later on as we progress in the presentation and in the discussion. So I'm going to share my screen now, and here we are. Okay, and do you see my screen?
Yes, we can see.
Okay, so I'm going to share with you this start here, actually, which the access evolution is really also our story at Axios related to access, because the story started 25 years ago with HIV/AIDS as an infectious disease. I work at WHO, and as a researcher in the beginning, looking for innovative treatment for HIV/AIDS. So when antiretrovirals came along, we finished the research, but the question for us was, how do we get it to the patients in most countries, especially the low and middle income countries? And there was a lot of discussions with the pharmaceutical companies, with the government, to actually try to find common ground. And we did some pilots, and these pilots were successful to prove the concept, and we moved on. So what the companies did was, the idea at the time is the price, and whenever we want to help people, we give them donation. So we worked really in the first, I would say, 10 years, in the years 2000, with a lot of donation programs that were meant for low and middle income countries, especially low income countries, related to HIV. And progressively, we started looking that, in fact, antiretrovirals were not only the problem, access to innovative products in general, and there were more and more coming in the area of oncology and NCDs, that these also needed treatment and needed access. So that's how we started working, also like increasing our portfolio from only HIV to oncology in the beginning, quite a lot of oncology, and then progressively with the other NCDs. So then around, I would say, 2006, 2007, we started thinking that, donation is not going to be sustainable. And there are many people who are actually not poor enough to receive the donation and not rich enough to afford the products. So in the end, you have that middle class patients that are not having access either. And that's how we came with a number of models for sustainable programs that are meant for non-reimbursed patients. It started mostly in middle-income countries. So we had, low-income countries kind of covered somehow in donations. You had rich countries that were reimbursing their products, and then the middle ground being shared. And as we evolved, we also found that with chronic disease, there is a peculiarity, is that the treatment is either very long or lifelong, and that has different consideration in terms of ensuring, exactly as you said, maximize the medical benefit. And most of you chose that because if we're maximizing the medical benefit, then we need to make sure that the patient is getting the treatment properly. So we started moving into holistic solutions in the access models. So this is just to give you an idea about how the thinking has evolved, and not only our thinking. I think the thinking of the whole medical community, as well as progressively the pharmaceutical industry, started moving. Before, people, when we talk to them about access, they say, access, what is it? What do we really need to do that? And now, there is no question about doing access. The question is how. And that was an interesting evolution. So what does it take here? And we will be looking at, in the first part, we'll be looking at what the problem is and what are the potential solutions, and then we can dive into more access aspects. So the question is exactly as you said. We had ballooning healthcare costs. We have many innovative medicine, many innovative techniques, diagnosis techniques, genetic mapping. So with all of that, we have ballooning healthcare costs. At the same time, the populations are aging and they are growing. We're over 7 billion now on this planet. Government spending, is not able to catch the increase in chronic diseases, the increase in aging, and the increase in population. So what end up happening is that imbalance, and then the government have to make a decision about what they cover and what they don't. And each government is adopting different strategies. Some governments decide to cover a part of the population more fully, others, and then get the private insurance. They try to do basic care for everybody, and then the rest, you figure it out. So it depends on what is it. But even in the rich countries, we are seeing this dilemma now more and more. So this is where these kind of specific solution for maybe specific disease area becomes important. And the other aspect that is not being taken care of is that you can, like for an antibiotic of a week or 14 days, you give a prescription and you tell the patient to take it. But when it takes years of treatment, then you need to make sure that the patient is not tired from taking the treatment or is not apprehensive of that lifelong treatment and end up not taking it. So these are the aspects that we looked at. This is just putting in numbers some of the healthcare expenditures in different settings. You see the high income country, you have a good proportion of public expenditure, which is green. The yellow is the private out-of-pocket expenditure. This is the private insurance. And then the 13% for high income country is the people paying out of pocket. When you move to upper middle income country, this proportion of people paying out of pocket becomes pretty important. The availability of insurance is less, but you still have reasonable coverage from the public sector. In lower middle income countries, the proportion keeps increasing in terms of paying out of pocket, and the proportion of public expenditure decreases significantly. In low income countries, it's expected, it's totally the reverse. You have little public expenditure, and most of the healthcare expenditure are really out of pocket. So it's clear that here you have different solutions for, you know, these different settings. And this is at the macro level. Of course, each country has its own specificity. This is just the coverage. When you decide you have a public healthcare expenditure and you want to increase it, then I would say you are torn in different directions. First is, do I need to reduce the cost sharing? Meaning, do I increase the proportion of how much we reimburse? Because many now, social security or even insurance, they do reimburse part of the treatment and not all of it. So this could be either in a package, or it is given as a percentage of healthcare, meaning, you know, they reimburse 70% or 80% of the cost of the drugs. But in this case, so if you have more money, do you want to reduce that cost sharing? Do you want to include maybe other benefits related to treatment, more diagnosis, or do you want to extend the uninsured? So these are very important because it depends on the policy. You could end up with having, for example, an extension to the uninsured, which is great, but you at the expense of the cost sharing, you know, or at the expense of insufficient coverage for other medicines that are maybe more expensive. So that's where you have a dilemma. And if you want to really cover everybody, then you have to look at these three dimensions in terms of whether it's in the private sector, private insurance or public insurance. You know, you still have these dilemmas in terms of policy. And it's interesting because each country will push one way or the other. I mean, driven by maybe ideologies or specific country context, or you know, different specificities. But it's important to recognize that if you really want to increase coverage, you need to think about these three dimensions that are important. One word related to what I said earlier about treatment follow-up. You know, I mean, I think whenever we talk to anyone, they say, of course, treatment follow-up. The question is, what does it take? And we moved from the medication purchase, which is extremely important, because if you can't purchase it, then there is no point of talking about the follow-up. But here there are a number of solutions that are important to help the patient purchase the product. But once the patient has purchased the product, this is not the end of the story. This is the beginning. And then what does it take to do that? And honestly, we have not focused on the treatment follow-up, although a part of all our program, we do have a follow-up. So I'll tell you the story of the follow-up more. We felt that now in itself, even for reimbursed population, then focusing on treatment follow-up is important, because the duration of treatment may end up being suboptimal if we haven't done specific things related to that. I think going to patient affordability So we look at these two aspects. One is patient affordability and what are the solutions we're going. Then we could look at the holistic approach where treatment follow-up becomes important. So I told you earlier in 2006, we thought about we need a way to make it sustainable for the pharmaceutical companies and for the patients to take their treatment. So the pharmaceutical companies cannot donate forever and everywhere. So at some point, they need to be able to recover their cost. And at the same time, we are asking them not to recover, to make high margins the way they do it in high-income countries. So we said, okay, well, let's see if we can ask people to pay what they can afford, as low as it can get, and basically, then contribute to the cost. What's important in this is that we needed to know how many people can afford maybe the full course of treatment here. And here we're taking an example where the cost of treatment is $60,000 per year. So, and that is significant amount, but you all know, I mean, as working in oncology, that this is a common treatment these days. So if they need to pay 60,000, then how many people in a country like Malaysia would be able to pay really 60,000? And so we modeled that, and now we have very well-established model that has been around for like 15 years. We estimate that there are 4.4% who can afford to pay 60,000 a year. Now, which means 12 months of treatment. And let's say how many are 11 months? That would be 4.9. So you could see that is 0.5% more. So it's a very steep curve. It means that, and that is very important, because if I will jump to 30,000, if we reduce the price of the product and we tell people, okay, pay for 30,000, we move from 4.4% to 10%, which is okay, but we're still at 10% population. The affordability started becoming much more important when we go down, at 25, 20, and 15. You see, we get 23%, 37%, 54%, and then 100. So this is important, because what we tell the company is that if you reduce 25% of your price, you're not getting anywhere. You need to go down. Now, at the same time, if they can't reduce it to that level where it becomes affordable to the population. So we came up in the end and said, okay, well, in this case, why don't we ask the people who can pay these amounts to pay them, so that they can subsidize the people who can pay less, and in the end, you have a reasonable average that is somewhere in the middle. And that was the thinking behind it. So that the old way where people say, okay, buy one, get one free, this works where you're buying some soaps in the supermarket. It doesn't work when your cost of treatment is $60,000 a year. Why? Because this is buy one, get one free. 30,000, you could see it. Now, the people who can pay more are paying less, are paying less than what they can afford. So basically, there is money left on the table. And the people who can afford less are actually not able to come into the program because they can't afford it. So that's why we say, if we take a program where the minimum is 3 or 2 or even 1, these people will pay more and these people will pay less. So in the end, it balances itself. And we could see that, when you get close to maybe minimum 2, then you end up in the 45% range. So a little bit lower than here. And it is about buy one, get one free. But the advantage is we have many more patients in this program. And that was our driver. And we've been doing that now for 15 years. And it really, really works in a sustainable way for the pharmaceutical companies, for the patients, and of course, for the doctors, because in fact, as doctors, we all want to see our patients getting the treatment, but the full course of treatment, so that we maximize the medical benefits. Now, we also, that was part of it. So still, when we look at the affordability of the program, this is one piece of affordability. It's easy to say, okay, well, the patient is going to pay 2 or 3 packs. 2 or 3 packs is still $10,000 to $15,000, so it's significant. And sometimes they don't have the cash immediately available to do it. So we started progressing into finding additional solutions and say, okay, well, if the patient cannot afford immediately, maybe we can ask them to pay in installment throughout the year, even though they'll end up paying the equivalent of 3 packs, but we're not going to wait for them to pay all 3 packs to give them the medicine. So we started looking at some cash flow facilitation. We call them short-time financing, but basically the idea is to help the patient out going forward. And that really kind of picked up quite a bit. We have similar programs also for the patients who have partial reimbursement. There are some social securities that provide, let's say, they say, we reimburse 70% of the treatment. Fine. The patient can pay 30, sometimes they cannot pay the 30%. We can help them pay the 30%. But what the Social Security says, yeah, we'll reimburse you, but in 2 months. It means they have to advance the treatment for 2 months before they get reimbursed. Here also they say, I don't have the money to advance the treatment. So here also there are some cash flow facilitation solutions that we help them. Our focus is to make sure that the patients, when they get the prescription, they are able to get the treatment, to be able to finance it according to the system that is put in place by the program related. And this is linked to how the healthcare system functions. And then make sure that the patient get the full course of treatment. This is really the objective and the driver of all what we do. This is the centerpiece of any design of program that we have. There is one word about treatment fund program. This is for rare diseases where very little could be actually paid, because these are very expensive treatment, maybe $100,000 to $200,000, and people cannot afford it. Nobody can afford it. So here you need to have external payers and put that in a fund to make sure that also we are able to help the patients. So I think I explained part of it even before that. The idea, as we said, the patient pay 11 cycles. So at least here we have finance 11 cycle and they get 1. Here they get 6 and 6. And here the minimum program, here we set it up at 2. And these people will pay 2 and will get 10 free. And these 10 free would be funded by the 11 cycles that were paid there. So this is just to give an idea about the sustainability. Now, how we look at that from the beginning, when we started in 2006, we said, okay, well, that's great. So how do you know that the patient can afford 9 or 7 or 8 or 5 or whatever? And so, I mean, I was thinking then, well, we can find some of these tools that are available to be able to understand, like there are tools that assess people's affordability. And as we looked at that, we couldn't find one. It's not that we didn't find tools. We found tools. Mostly these are charities that differentiate between the rich and the poor, which is important to differentiate between rich and the poor. But here we're looking at more granularity. We wanted to make sure that we're also differentiating between the rich and the very rich, so that we are able to look in more details about it. The banks do that. But the difference with the banks, because if you want a loan, they are going to assess your wealth to make sure that you reimburse it. But it is in your best interest to actually tell the bank that you're rich, because otherwise they will not give you the loan. In our case, it's not in your best interest to say that you can pay. So this is where we ended up developing our own tool based on a number of macroeconomic indicators, based on the World Bank surveys that they do related to that, looking at 3 factors: income, assets, and standard of living. And these are adapted country by country and adapted to the disease area, but is essentially country by country, to make sure that it does capture the wealth, it does capture the income, and it does capture the assets. And based on that, we agree with the patient and say, okay, you can pay 4 packs, 4 months worth of treatment, and but we work with the patient on how this is going to work throughout the 12 months treatment. Now, we know in some cases that in oncology, unfortunately, there aren't 6 months, there aren't 12 months worth of treatment, but you can't tell the patient, well, the survival is only average 4 months, so we're going to work 4 months. We have to work on 12 months. And then the way we put the treatment plan is fair for the patient, so that if anything happened and the patient has to discontinue the treatment before the 12 months, then they can do it in a very reasonable pay, and they wouldn't have paid more than what they would have paid in the year. So that's how we structure it, actually. So we develop that treatment plan for patients who need more than 1 year, and this is very important in chronic diseases. Then we work on a yearly basis, meaning we reassess the patient after a year, because all the economic indicator, macroeconomic, but also microeconomic, are linked to household income over a year. It's linked to the GDP, it's linked to what we call Gini index. There are a number of things. So we look at the yearly consumption of the patient and the yearly cost of treatment, and we adjust it. And then we say, okay, well, next year we reevaluate, we see how you are, and we continue the treatment based on that. So this is how, in fact, we ended up having our own tool. This tool has been validated, published. We have 2 publications related to that, and we've been using it since 2007, actually 14 years. And we also looked at what patients were supposed to pay and what patients actually paid. And then we also looked at what happened to the patients that paid. I mean, we didn't want them to take their kids out of school to pay for the treatment, and we found that fortunately they didn't. So all these validations happened over the 14 years and made sure that it is that it's fair for the patient. This is the second publication that we've done, which was pretty interesting. It used, these learning machine big data with our software, and here it's in these methodologies, the software classify patients in clusters, and these clusters have common features. In this particular case, obviously these features were related to the wealth of the patient. So you could see here you have, the people in red who are overall wealthy. The people who are in yellow had rather high standard of living and asset. The purple ones are high standard of living only. These ones, the blue, are actually overall poor, meaning they have low standard of living, assets, and income. And finally, the clusters that are in green are high assets. This publication is published and available, but it's interesting to look at it and to look also how it differentiates. So these are standard of living here, these are globally poor, and this is more income. So in Thailand, for example, the income is not the driver. We couldn't find here, the income as driver. When you look at the income, you see it's very low almost everywhere. The blue being low, and the red is high, and then orange is kind of in between. So you can see like income is very poor indicator in Thailand. It is the people who are overall wealthy have the 3 indicators high. The assets, we start capturing more population who have actually some money, even though they don't have declared income. And the standard of living also captures. So when you put them together, you end up capturing the wealth of more people. That's why these 3 become important. In the United Arab Emirates, we have a similar distribution, but you could see here that it goes of the income is more prominent together with the overall wealth, because the population in the UAE, 80% of the population in the UAE is not actually local. They are foreign workers, so they don't have assets. They don't own assets in the UAE. They probably own assets in their countries of origin, but we don't know that. I mean, and they're not going to tell us. So our most reliable indicator here is the income. Look at the assets, is very little, and the standard of living. So income and standard of living are dominant in UAE. In Thailand, it's standard of living and assets. And in Mexico, finally, you have same in terms of income is important. These are the globally wealthy, and you also have standard of living that could help. You could see it here, and some of the assets. So it's more balanced in Mexico than it is in the others. So just to give you an idea about how the financial assessment is important in capturing and being fair to the patient and making sure that the patient can pay what they can afford, but without also disrupting the household. So this is just an idea about the variation between the countries. The short-term financing, as I mentioned, if you have to pay $600, then we split it over 6 months. This is pretty, basic math. And the cash flow facilitation, as I mentioned, so we do the same. Now, when there are insurances, it's interesting because, you know, if the patient has to pay the first month or the first 2 months before they get reimbursed, this means we have to wait until the end of the treatment for the patient to reimburse us these first 2 months, because every month the patient has to advance the new treatment. So it is a running cycle, and when they finish the treatment, they reimburse us. And our experience has been pretty favorable in this, because the patient do pay back their dues, even the patients who discontinue treatment. You know, even the patients who actually passed away, their family reimbursed, came back and reimbursed no money. So it was very favorable, very interesting experience that we had, and it's working very well. Now, the treatment fund program, as I mentioned, you need external donors, because the patients, like relying only on the patient is not possible. And sometimes it could be part the government, NGOs, you need the pharmaceutical companies to give some of their product, some public funding entities, charities. So you need to make sure that you have in the fund enough money to supply the patients. Now, this is where the idea started. Then we said, okay, well, at some point, even if we have a patient, we know who can afford some, they need some money to, they need some time to find the money, but also the charity is willing to pay a little bit of it, even if they cannot. So when there is multiple funding, then we try to put them together so to facilitate the payment for the patient. And so that when we get the prescription, the patient is put on the product, and then we work out the financing. It doesn't happen in all the countries, because we don't always have this facility and external funders who could help the cost sharing, but we're trying to make it available as much as we can in as many countries as we can, so that we don't have the patient waiting for a week or 2 or 3 before they start the treatment. So we try to do that, but it's slow to be put in place, because for obvious reasons you need to get all the stakeholders together. But I think ultimately this is going to be very important for the patients. Now, this is an idea, this is a case study of hematology patients. The product cost about $96,000 US, or 390 ringgit per year. We had 150 patients overall. They all got a financial assessment, as I explained before. Now, in this treatment, the medium, there is a medium. So this is treatment that is finite. They get a number of cycles and they finish. The cycles are maximum 16 over a year, could be 8, and that should be in around 6 months. So the expected duration of treatment in average should be 6 months. And the median 7 months. And you could see here that that survival was very important. This dip is actually not a dip, it's just at the end of the program. But it's very interesting to see, you know, how it has evolved progressively, and that we had 80% of the patients still on treatment at 6 months. So that shows you that, you know, even though the average of treatment is 6 months and the maximum treatment is 12 months, we still had 70 patients who completed their treatment, which is very important in terms of adherence. And this is this was a very good example about how people continued their program. So we also looked at the satisfaction. What do physician and patient think of the program? You know, I mean, patients and physicians were happy. They felt that they could afford the program, and they were happy that they could finish the program, and it's pretty substantial. And this was an interesting case study because the treatment saves life, and at the same time it's finite, it's 12 months, and it was completed. So we could see the end of the tunnel, if you want, and we could see that it's really it was really followed very well. Now, open discussion. We put this, but we don't have to follow it, you know. Let me pause here and maybe see if there are people who are, I will and see if there are people who are raising their hands. Johnston, I will need you to help me in this if I miss some people. Are there any questions before we open the discussion in this? Are there any questions that people would like to ask? And maybe even, why don't you all put your video so that we can see you all?
Yes, doctor. I'm sure we can do that for those. So it's just that some people, I think, are not in a very easy place to put on videos. But I think they're very able to put on voice, I think, yeah. As well. So we could have you put up hands, or just unmute and please go ahead.
Okay, so if there are less people available, you know, there were, I would ask the question and would be interested to hear your views. Of the solution that were discussed, have any of your patients been on these programs, and what was their experience according to you?
Yeah, and feel free to unmute yourselves to answer the question, or also feel free to write into the chat as well. If you want to write into the chat, I will monitor the chat.
Okay, to kind of perhaps kick off the batting. Yeah, for me personally, I know there's quite a few of my patients who are on various access programs, and I think the current kind of version or the make of most of these programs are largely your 1-to-1, as in, or your 2-to-1, 3-to-1. So you buy 2 and then there's a free month. As a 3, you buy 3 months of supply and then there's a free 1 month. So and a couple of challenges, I think, in Malaysia pertaining to this as well. For a lot of patients, a lot of these treatments are covered as long as they are on inpatient. And the moment they actually get off, then their medical insurance is not going to cover it. So a lot of them fund this through life insurance payouts. So, you know, when they get their critical illness diagnosis, for example, in cancer, when you're diagnosed and your life insurance gives you a payout, that's what really is being used to kind of fund these treatments. But interestingly, a lot of people have insurance from a very older generation, meaning even for me, my life insurance for a long time was on a very small scale. I think I had about 100,000 or 150,000 ringgit, and that was it. So if I had a cancer diagnosis, I would get a payout of that lump sum of about 150,000. But as you know, that's going to go nowhere in terms of actually funding treatment. So that's one of the big problems. On average, most patients I know are comfortable paying for paying for medication of about up to about 4 to 5,000 ringgit for about 24 months. And after that, they start to either fall off the wagon or just are unable to purchase. And then their physicians have to look at alternatives for them to continue being medicated.
Yeah. So this is where it's important to look for various solutions so that it doesn't deplete, all their savings. It doesn't make sense, and we do take that into consideration when we review when we do their financial assessment. Make sure that it does not deplete their savings. Yeah, important. Well, thank you. And what additional affordability solution do you feel would be beneficial to your patient? Like, what would you like to see? Because you told us about your, the day-to-day situation, but what solutions would you like to see for these patients?
Oh, so in terms of for a lot of, and I'm speaking very narrowly about cancer now, I think for me, there'll be a big advantage if I have patients who are able to if patients are able to kind of get financing for this packet of treatment that they need. That's one thing. And so then you can speak about maybe getting something like an intergenerational loan of sorts. We talked about microfinancing earlier as well, but maybe something that they can co-pay together with family members or children, which is still the case in Asia, where a lot of children actually help fund their parents' treatment as and when they do get cancer. So the problem is banks don't fund these things. Financial institutions at this point in time don't kind of kick in these loans at low interest or something which is so that might be something which is very helpful for in order to fund treatment as well. And maybe it could be underwritten by, say, public institutions, in the interest, in a larger interest. So it could still be generating a little bit profit, but of course not terribly commercial.
Yes, and even by some charities who would be willing maybe to step in, like put some revolving fund, knowing that they are taking the risk, but they are not necessarily like paying everything themselves. That's the spirit of that treatment fund that we talked about. But it will probably mature over the years. But you're right. I mean, in the end, you need also some kind of alternative solution. Doesn't always have to come from the healthcare system. Yeah. Okay. Any other thoughts before we move on?
Oh, I mean, and perhaps it'd be good to feedback to you, Dr. Saba, and possibly because this is helpful for kind of when you deal with global pharmaceuticals and all that. One of our big asks is this indefinite prolongation of treatment is one issue, but the indefinite prolongation of costs is another issue. So, for example, I have a patient who pays now in ringgit about 27,000 ringgit a month for this high-end immunotherapy, and that what does that work out to? About $7,000 a month. So what the family does have is a limited amount of savings, and they're willing to commit that, say, about $500,000 or $250,000. Again, these are very, very how to say, high-end patients, I suppose, able to pay. But even for them, when you can't see the end of the tunnel, for example, okay, if I am like very sure that, okay, I'm going to pay for about 12 months, and then after that, the cost of the medication is kind of taken care of itself subsequently, this will also really help people have a perspective of because again, with the loan, if I know I'm going to fund my car or house for 100,000, I know how to save and pay for that. But if it's going to go on forever, there's no way I can fund these things.
Absolutely. Yep. Absolutely. You're right. And and these are like the lifelong chronic treatment, how we can help. I mean, if you don't have recurring sources of funding, it's very difficult to fund, because in the end it will dry up. Yeah. Okay, so maybe we can continue.
Hi, sorry, I do have one question.
Please.
Yeah, so I'm coming from the pharmaceutical side, and I was just wondering if you had any kind of unprecedented problems that arose when you're implementing these affordability programs in Malaysia specifically.
You mean unexpected?
Yeah, unexpected.
We always have plenty of unexpected things that happen, but they actually, you know, the initial, and it's in Malaysia, but also in other countries as well. Initially, when we come to these kind of solutions, there are different pieces of resistance. First, you know, like the doctors would say, yeah, you need to financially assess the patient. You know, like, why do you want to assess the patient? This patient needs the product, give it to him. So there is a resistance related to the principle of financial assessment, but it ends up like being overcome, because in the end, the end goal is to get the patient the medicine. So that end up, but there is, if you want, kind of in the beginning, we have to overcome resistance, not only in Malaysia. In Malaysia, actually, it was easier than in some other countries. But yes, so that's one of the aspects. The other aspect that usually is something that we see at different rates, is that, like, why is the patient, like, why am I paying $3 and the other patient who is in the waiting room paying $2? Yeah, and that's also something that we face. But in the end, they do understand that you pay what you can afford, and there are even some, I would say, doctors, but also policymakers who come and say, but you know, this is unfair, because you're asking patients to pay different amounts for the same treatment. But in the end, the equity for us is make sure that the patients get the full course of treatment, because that's what matters most. And yes, it is like in the Social Security. In the Social Security, you pay a percentage of your salary and you get the same treatment in the end. But if you earn a higher salary, you're going to pay more to the Social Security than you get lower salary. So if we think about it that way, these are many unexpected things that happen, and now we don't know when to expect them. We just have to deal with them when they come, you know. I don't know, Johnston and Rochelle, if you want to intervene in terms of what other unexpected events we see specifically in Malaysia.
Yeah, I can add to this a little bit. I will say that implementing these programs in Malaysia, as Joseph has said, we have faced less resistance in Malaysia, probably compared to other markets. And I really think that that's because the oncologists that we've worked with really recognize that there is certainly a very high unmet need when it comes to their patients being able to access treatment. And when I say unmet need, I say both from an affordability perspective, as well as kind of a maximization of patient benefit perspective, right? I think that a lot of oncologists, they saw that the old way of doing things wasn't really working, right? If you were to implement a buy one, get one free, or a buy two, get one free, the issue with these programs is that they typically don't take into consideration the entire duration of treatment for the patient, right? So you saw in our affordability curve earlier that even if you were to implement a buy one, get one free treatment, it doesn't really reach a very large percentage of patients. And what we see with these programs is that even if a patient does join, let's say a buy one, get one free program, they will drop out, or there's a high chance that they will drop out of treatment prematurely before they can maximize their benefit from the treatment. And I think that's one of the reasons why the doctors and oncologists have been so receptive to the affordability model, because it really provides an individualized approach. And because we're addressing the individual affordability barrier of the patient is able to stay on treatment for much longer, and we've seen very, very high acceptance because of that. So in general, we haven't actually had too many challenges in terms of implementing these programs, and we continue to see pretty high momentum in terms of uptake.
Great. Thank you, Johnson.
Thank you.
Okay, so maybe we can move to the next piece of presentation, which is related to what we call the holistic support. And in fact, now we can talk. We'll talk about that, but I'll tell you a little bit how this came about. From the beginning, when we did our programs, we included obviously a follow-up piece related to the program, and to follow the patients to make sure that the patient is getting the free of charge that they are entitled to make sure that they are getting their treatment and all of that. So what happened is, and that was really started initially in the UAE, because you have a proportion of the patients who is fully covered for all the treatments, and a proportion of the patients who is not. And here what happened is when we looked at the duration of treatment in our patients who had affordability problems that we solved, but also that we followed over the time, the duration of treatment was more than double the actual duration of treatment of people who are fully covered. So this is where we started saying, maybe we need to do something for the people who are fully covered. We're no longer in affordability here. We are in adherence to treatment. And it was very interesting. And you could say that, well, but this is something that the doctors can deal with, no doubt. As a doctor, I know that this is our duty, we need to do it. But these days, doctors are so overwhelmed that they cannot focus on all what's needed. And when we started these adherence programs, that was the question of the doctors. You're doing my job. I mean, this is not what I would be expecting, is that you come with a program to do my job. But effectively, when we dug deeper in it, we weren't doing the job of the doctor only, because there are many factors related to adherence, social, behavioral factors, perceptions, you had family pressures, you had community pressures. So it did require a different way of dealing with these aspects than just, unless the doctor turned into psychotherapist, which is a different story. And it reminded me, honestly, when we started with HIV patients. With HIV patients, we ended up having peer education, psychosocial support, helping patients in, finding job, get integrated in job. We had social workers working with us on that. So we understood that handling HIV patients with or without treatment needed actually an infrastructure on its own to support the patient. It does require a different way of support. Well, we did that for HIV, but we didn't extend it to the other disciplines. And I think for certainly NCDs and chronic treatment, we need to. So looking at it from that holistic aspect, we felt that if you look at this diagram, you're going to find that there is in the hospital and outside the hospital, but it's a continuity. So you have the hospital treatment administration, you have the medical management, which is extremely important. And then, well, we can help patients who need financial assistance, you're related to affordability, but all the aspects related to patient engagement and psychosocial support. So today, what's interesting is when we prescribe to a patient and tell them, okay, come next month or come in 3 months, depending on the treatment, we don't know what happens to this patient during these 3 months. And if the patient needs something, if it's urgent, they will call the doctor. If it's not, they will not. So, and many things happen during this period that does influence treatment adherence, that does influence the perception of the disease with the patient, the perception of the treatment, the apprehension of the treatment, apprehension of side effect, all these aspects. So how did we move with that? Interestingly, so we went to what WHO did. WHO identified 5 dimensions for adherence as they started tackling NCDs. They said it's social and economic dimension, obvious, a treatment-related dimension, patient-related dimension, their own psychology, healthcare team and system dimension, meaning it's linked to the type of care and how they are getting care at the hospital, and then the condition which is related to the disease area. So we said, okay, if we have all these dimensions, so how do we know where the problem of the patient is? So we devised a tool called Patient Needs Assessment Tool. We have PFET and PNUT. PFET is the financial assessment. And we devised the tool with questionnaire related to these 5 dimensions, where we identify what are the issues that bother the patient in relation to the treatment. Is it related to the fact that they don't have enough time with the physician or with the healthcare personnel, or is it because they are afraid of side effects? Do they understand enough their disease area? Are they influenced by the neighbor who said something, or by the community who is resistant, or are there stigma related to that? All these aspects are important, because if we want to help the patient, we want to know what the problem is. And it is different in different patients. So this is basically what we've done. Based on this assessment, we identify what are the factors, the risk factor that could lead to the patient discontinuing the treatment, and we work with the patient. We have an action plan. We work with the patient in addressing these issues. Now, we had, as I said earlier, huge resistance from the physicians in the beginning, because they were saying, you're doing my job. But progressively they understood, the value. And now, the most reluctant are the ones who send us most patients, because they are really, they could see really that this is helping them and helping the patients. So, well, I mean, I think you know the slides, like it decreased. Why do we need that? It decreased dropout rate, increased duration of treatment, decreased the burden of the healthcare, improve long-term medical outcome, and reduce costly insurance claim of disease complication and complicated surgeries. This is an adherence program done for. Actually, it's a case study related to psoriatic arthritis, which is a long-term treatment. And just to give you an idea about the difference between with program and without program, we doubled the average duration of treatment. All the other figures speak for themselves, but for me, the most important one is that the patient could stay on treatment twice as much because we did address with them, some of the issues that could have led them to stop the treatment. So this was really a very positive experience. Now we have many programs related to that, and we feel it's important. Of course, some of these elements are already included in our affordability program because we're following the patients, and now we are validating the PINA tool, and you're going to see here some aspects. One finding, there are several findings. It is about to be published, but one of the findings is that the number of interactions between Axios and the patient was proportionally correlated to the increase in duration of treatment. It's an interesting finding, is that the more you have interaction, the longer the patients were on duration of treatment, and that's important because everyone is going digital. We also are completely digitalized, but having the machine, talking to the machine, is not as efficient as speaking with the patient on the phone. You see, look at the email versus the phone call, and it is important, and that's also a big learning for us, is that you need a human interaction, maybe less with the digitalized system. Now we need less human interaction, but you need human interaction. The people who are designing systems that are entirely digitalized and speak to the patient without human intervention, from our data, it doesn't seem to be as optimal as if we had a minimum of interaction with the patient. So we're looking at that more closely now in the analysis, but also in our day-to-day work. And the other aspect that is coming out, and we will be publishing in this, is that if you look at the social aspects versus the treatment aspect, the patient is going to tell you, for example, that they have some apprehension of adverse events, but when you dig deeper, you find that the reason they have this apprehension is because they are heavily influenced by their environment, and that the neighbor told them about the adverse event, and now they are apprehensive. So social and community factors are very important in inducing the perception related to the disease, and this is another dimension that we will be showing in the publication, which will lead us to dig deeper into these aspects, because if we don't address it, then the perception will not change, even if we deliver full education on the disease to the patient. So these are important aspects. One could be because the patient don't know, but in many other cases, it's not because they don't know, it's because they are influenced by their community. And that is also another important aspect to think about. Maybe we can go for the poll.
Yeah,
John?
Sure, absolutely. So we're going to have a third poll that is related to this discussion about solutions beyond just affordability. So we wanted to understand, from the participants' perspective, what are some of the other challenges that your patients face that are non-affordability related? So I'm going to open this poll now. So the poll is open now. So the poll is, other than affordability, what challenges do your patients face the most? And again, you can choose your top 2 answers here. Is it fear of treatment and side effects? Is it inability to get to the hospital for treatment and follow-up? Is it a lack of understanding about the disease and how to manage the disease? Is it a lack of social support, or is it something else that we haven't mentioned here? And I'll give everyone a few minutes to answer the poll. About 60% of participants have answered, so I'll just keep it open for another 20 seconds or so, and then we can discuss the results. Okay, great. So I'm going to end the poll now and I'll share the results. So the top 2 answers are fear of treatment and side effects, as well as lack of understanding about the disease and how to manage the disease. So Joseph, I'll pass it back to you.
Yes, well, thank you. Well, absolutely. I mean, this is also what we found in the beginning when we did the peanut, and we found these are the 2 clearly dominant pieces, and that's why this analysis proved very interesting, is because when we looked at it in the, I would say, the traditional method, looking at the different the different questions and how people responded, this is what we found. So I'm sure, like here, the participants, you are really reflecting what you're seeing and what we have seen. But then when we started looking at the correlations, and that's using the R, similar clustering method as what we've done with peanut. When we started looking at the correlation between, for example, the lack of understanding of the disease and some of the social problem that the patients are facing, and same for the fear of treatment side effect, especially for that, then we found that there is very heavy correlation related to it, which is important. It doesn't change the result. The result is exactly as you captured them here. It doesn't change the result. It changes the way you address that, because like fear of treatment side effect, we can educate the patient on treatment and side effect. And what we are finding is that maybe that education on treatment and side effect is not going to be enough unless we address the deeper cause of this fear. And it would be for the understanding of the disease. So we definitely need to continue to educate the patients on the disease, on how to cope with the disease and treatment side effect. But there will be interventions related to social support that are needed so that we can overcome these fears. It's not going to be enough to educate them on it. That was my point. So, really, I would have said you reflect exactly what we have found with that peanut analysis. So it's interesting. Yeah. Thank you, Johnson. So we can move maybe to the last piece of we have a discussion. Yeah, that's the poll. So are there any other challenges not in the poll that you believe the patients face most?
And there were, I think, 2 or 3 participants who said that there were other challenges that were not in the poll. Would those, 2 or 3 participants be open to sharing what those challenges are?
No?
Okay. If not, it's okay, but we can open it up as well. Are there any other challenges? Yeah, go ahead, Joseph.
Maybe they can, sorry, maybe they can write it in the chat.
Yeah, they can write it in the chat as well, yes.
Yes, you wanted to say something, Johnson?
No, that's okay. Yeah, so Joseph, we have one comment that says lack of family support from the husband or from children.
Yes, yes, absolutely. And these are some of these psychosocial factors that are important, especially for patients who either live alone or live isolated from their families. So yes, absolutely. And that has come up also in our survey that we've done. And that family support is a very important actually social support that help patients cope with their disease in general. And basically, when we did the analysis, our key element was the patient telling us that they feel they are able to handle their disease, to manage their disease, and these correlations are linked exactly to that. So no, thank you. That's a very relevant one. Any other? Okay.
So sorry, Dr. Saba, just gonna add in. Okay. There's one more comment as well, but I'm just gonna throw in the kind of impact of psychosocial, the inavailability of psychosocial support. I think might be a big factor as well. Within within our public sector, we actually have access to psychological kind of counseling, those kind of allied health professional support, but unfortunately the kind of numbers in terms of availability, access across different institutions is very limited. And in the private sector, actually, it's quite widely available. Again, it becomes an issue of affordability. In many instances, these things are not covered by insurance, so patients have to end up paying out of pocket, and as a result, it just becomes impossible for them to actually get the support that they need without kind of paying out of pocket for this. Just to kind of share a weird kind of finding. If you were diagnosed with cancer and you got treated for cancer in a private hospital, you cannot actually get a psychiatrist to see you within that same pocket and get reimbursed. What's even more odd is if you did get a psychiatrist, for example, to see that patient on that cancer admission, the patient actually risks the entire reimbursement, the financial reimbursement, including for the cost of treating the cancer, to actually be not reimbursed at all. So
here there is education not only to the patient, there's education to the insurance.
Yeah,
that becomes important, that these things are interlinked, and actually you would be wasting a lot of money in reimbursing a treatment that in the end the patient will stop because of these issues.
exactly.
Yeah. No, thank you for that insight. Very, very interesting, actually, to know that the fatalistic approach of life is a belief and behavior, and I'm sure we cannot pretend that we're going to solve all of these aspects, but you're right. And the question then is to try to understand if the patient is going to, if there are any social support that could help the patient accept the treatment. For some patients, probably it won't work, but absolutely, I mean, these are things that we find. We have more afraid of side effect. Yes, that's what I was mentioning, is that they feel they are unable to do it. Sometimes it's because they don't understand the medicine, like the treatment, and then an education. But I'm sure, all of you really explain to the patient, what to do with the treatment and the potential aspect. Then they read like the long package insert, and they find plenty of things, and they don't always have like the statistical education to differentiate between them. That could help as an education. But beside the education related to this, we can find also that sometimes it's because they heard the neighbor who had a problem and now they're afraid. So which is really slightly a different aspect, and this is where social support would be helpful. So we have more governments must control the price of anti-cancer drugs across the board, including costs charged by private hospitals. I mean, it would help to control the price indeed of it. That's a policy issue. We tend not, we at Axios, like we usually tend not to interfere with the government related to their policies because we don't have that mandate. But it doesn't mean that it's not needed. What's interesting, and we could see it in the COVID epidemic, because it's one epidemic, you could see how different governments reacted to the epidemic, and it is the way the different governments react to it. But yes, that's definitely something that is important to do. What we try to focus is more on the patient level and make sure that in the end we solve the problem regardless what the government policy is. Okay. The two code words for attendance today will be access and support. Yes. Yes, thank you. Absolutely would be. Okay. So I hope you had a good overview of these aspects related to access, and in the end, the holistic meaning of access, that is not only an issue of affordability, it is doing all what we need to do, regardless whether it is financing, whether it is affordability, whether it is social support or improving adherence. In the end, what's important for us is to make sure that
there will be on access and support.
Sorry?
Sorry, not coming out of me, Dr. Saba. I'm not sure where that's coming out of.
Hello? Yeah, okay. No, so I was saying what's important in the end is that we put at the service of patient all the tools that we have to ensure that the patient gets the full course of treatment in the end. That is what is the most important aspect from our side, and then we'll do what it takes to ensure that the patient complete the treatment.
Right. Thank you very much, Dr. Saba, and of course, Johnston, for this very enlightening session. And I think, as I was saying at the beginning, some of us are increasingly moving towards other kind of options. We need to review not only writing prescriptions for the patient, but really think more holistically about how our patients are going to continue receiving the care that they need over this point in time. And I hope that it's been very interesting for me, and I hope it's been as interesting for the rest of our colleagues who have joined us in this session. Ladies and gentlemen, just two housekeeping issues. First is, of course, the code words in terms of attendance. I've put them on the chat as well. They're access and support. So go ahead and kind of put that in as in the email that you receive. You'll have the link to kind of put up your attendance for CME points, so that will be done as well. And please allow me to again thank Dr. Joseph Saba and Johnston for joining us and sharing this evening. Hope you all have a wonderful weekend, and hope this was interesting for all of you all. Thank you very much.
Thank you. Thank you very much.
Thank you all.
Thank you, everyone.